Occupational English Test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12.
You hear a physician talking to a patient called Mrs. Gonzalez. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, when I was walking into a store yesterday, I felt dizzy and had some cold sweats, some shortness of breath, but there was no chest pain, nausea, or vomiting. I suddenly sat down and lost consciousness for a minute or so. However, there wasn't any tonic-clonic movements.
What's your age?
48.
Did you had any cyanosis, which means that the skin goes bluish?
No, doctor. Then I got up on my own, and even now I'm having mild shortness of breath upon exertion. This is totally unusual for me, doctor.
Do you have any fever or syncopal episodes?
No, doctor.
Have you had any diseases or surgery in the past?
Well, a year ago, pulmonary embolism was diagnosed. But during that time, I had an IVC filter placed due to massive gastrointestinal bleeding diverticulosis and gastric ulcers, paroxysmal atrial fibrillation, and no anticoagulation due to history of gastrointestinal bleed. Coronary artery disease status was post-bypass graft surgery at that time. I had to stay in the ICU for 3 weeks due to lower GI bleed again.
Okay. What medications are you taking now?
Aspirin, potassium, Lasix, levothyroxine, lisinopril, Pacerone, Protonix, Toprol, vitamin B, Zetia, Zyrtec.
Are you allergic to any medicines?
Yes, to sulfa.
Well, your blood pressure is 155/57. Pulse rate is 61. Respiration's 18, and oxygen saturation is 95% on room air. No lymph nodes or masses. No lower extremity edema. No redness or hotness. The laboratory reports show creatine 2.1 and hemoglobin 9.6. Your chest X-ray is clear. You have developed pulmonary embolism with contraindication to anticoagulation due to recurrent gastrointestinal bleed. Status post-IVC filter. You have also developed mitral valve disease, coronary artery disease, and peripheral vascular disease per cardiology. No evidence of chronic thromboembolic disease per VQ scan. We cannot rule out pulmonary hypertension. Shortness of breath upon exertion. You will need a pulmonary function test as an outpatient. I will do oxygen saturation with ambulation to prevent it causing loss of consciousness. Extract 2. Questions 13 to 24. You hear a doctor talking to a patient. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Yes, good morning. What can I help you with today?
Doctor, I'm getting a throbbing pain in my right shoulder.
How long have you been experiencing this pain?
For the past 5 months. But the pain has worsened in the last 2 months. The pain aggravates as I'm a regular baseball player that involves throwing. Now I am also participating in basketball.
What is your age?
21.
Oh, I see. Do you take any medication?
I was taking non-steroidal anti-inflammatory drugs and muscle relaxant medications.
Are you allergic to any medicines?
No, doctor.
Have you had any surgery or any diseases?
No.
Do any of your family members have any diseases?
Yes, my mother has arthritis.
Do you drink or smoke?
No, doctor.
Well, your blood pressure is 116/68, respiratory rate 16, heart rate is 68, and weight 165 pounds. Your right shoulder shows evidence of swelling and tenderness. Radial pulses are 2/4. Bilateral. Brachial pulses are 2/4. Bilateral. Range of motion of your right shoulder shows decreased flexion, decreased extension, decreased adduction, decreased internal rotation, decreased external rotation. Left shoulder is normal. External rotation is fair. Internal rotation is poor. Rotator cuff impingement is moderate. Your X-ray report reveals presence of cuff arthropathy. You have developed rotator cuff syndrome in your right shoulder. Actually, the rotator cuff is a group of muscles and tendons surrounding the shoulder joint. A rotator cuff injury causes a dull pain in the shoulder and often worsens when you try to sleep on that side. Often, rotator cuff injuries occur in people who perform overhead motions repeatedly in their jobs or sports. Without treatment, rotator cuff injuries may result in permanent loss of motion or weakness, which may result in progressive degeneration of the shoulder joint. Although resting your shoulder is essential for the recovery, keeping the shoulder immobilized for a long duration can cause the connective tissue to become thickened and tight, a condition called frozen shoulder. I am prescribing you Vioxx 25 mg tablet once per day. I am giving you an injection to your shoulder joint with Celestone Solispan 1.0 cc. If the condition is not improved within 15 days, then I would order an arthroscopic tendon repair in which a tiny arthroscope and tools are inserted through small incisions to reattach the torn tendon to the bone.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Question 25. You hear a nurse talking to a patient who's about to have a mammogram. Now read the question.
So, have you had a mammogram before?
No, I haven't, and I do have a few questions actually. Like, what about the radiation? Do I need to worry about the dose? Is it likely to be harmful in any way?
No, it's very low. In fact, it's similar to the amount you'd receive if you took a long-haul flight.
Oh, yes, that reminds me. When will I hear? 'Cause I'm away in New Zealand for a month from next Wednesday, and I'd like to know as soon as possible.
It'll take about 2 weeks, but if you're concerned, we can give you a number to call.
Oh, thanks. That'll be a real help, actually. Then, for me, the big question is it going to hurt? I've been hearing gruesome stories from friends, and my anxiety levels are going through the roof.
Okay, I understand. Perhaps you could tell me exactly what you've heard.
Question 26. You hear a doctor talking to a patient about a blood pressure monitor. Now read the question.
It's like a normal blood pressure monitor, but it's mobile. You wear it on a belt around your waist and it's attached to a cuff on your arm. Then you just go about your usual day-to-day activities and it takes your blood pressure at regular intervals. It's more accurate because we can avoid what's called white coat syndrome. It beeps first, usually every 30 minutes or so. When that happens, you should sit down if you can, Hold your arms still and keep the cuff level with your heart.
Do I have to wear it at night?
Yes, you do. You could put it under your pillow. It needs to stay on for 24 hours, though you don't have to wear the belt.
What about showering and stuff?
Well, I was about to say, you should avoid that, I'm afraid.
I see.
Question 27. You hear a dentist and her assistant talking about a problem with some sterilizing equipment. Now read the question.
Oh no. It looks like the autoclave is playing up again. The temperature's only 117. That's 4 degrees lower than I set it for.
Yeah, I noticed that. Yesterday it was at 119 and I just couldn't get it to go any higher. Shall I have a look in the instruction manual and see if I can sort it out?
Well, that might invalidate the warranty. Could you find out whether the one next door's working properly? I expect it's because the hard water around here's caused a build-up of scale and that's affected its efficiency. Perhaps you could ask reception to get the company to come out as soon as possible. If they can't come tomorrow, we'll have to wait until Wednesday and make sure everyone knows it's out of order. If you could send a quick group email, that'd be great. That's the second time this has happened and it's still under guarantee.
Question 28. You hear a GP talking to a patient with hay fever. Now read the question.
How can I help you today?
I need something to help me manage my hay fever this summer. It's already become unbearable. I don't want to have to stay indoors when all my mates are out enjoying the good weather. We're all off camping next weekend, and I'd hate to miss out on that.
What's bothering you in particular? Perhaps I can give you something to make you more comfortable.
Well, I keep getting this horrible headache thing. It's like at the top of my nose, and it's really getting me down, to be honest. Then there are the watery eyes. I mean, I can feel them puffing up as soon as I leave the house. They're so itchy, red and painful and look awful. I've got a summer job working at music festivals, so there's no escaping. I'm literally in fields all day, every day. Is there something you can give me?
Question 29. You hear two nurses doing a patient handover at the change of shift. Now read the question.
So, in bed 6 we have 83-year-old Mr. Beard.
OK?
He was admitted this morning and he's been diagnosed with bacterial pneumonia of the right lung. He's quite poorly at the moment, but stable. He's lactose intolerant, so can you talk to the kitchen and organise something suitable for him?
OK.
Otherwise, he has no known allergies. He's been for a chest x-ray, but we're still waiting for the results to come through. We may need to do a CT scan too, but we'll have to wait to see what the x-ray results reveal before we can arrange that.
Right.
His SATs were at 57, so he's on 2 litres via a nasal cannula, and that's to be reviewed after 2 days, so not until tomorrow morning.
Mm-hmm.
Oh, and I forgot to mention, he had a fever of 39.4, so he's also on antibiotics via IV, which he's not very happy about.
Question 30. You hear a hospital manager briefing newly recruited staff about patient safety. Now read the question.
Within the information team, we provide a set of standard and custom-made reports to suit the needs of staff and patients. Our aim is to provide information into the patient's journey, from their arrival in the emergency department to their discharge from outpatients. One of my responsibilities is to ensure that the information we provide is clear, easy to understand and straightforward to use, so that we can look at areas of concern, things that are common across departments, and reassure ourselves that we are delivering quality care. When things go wrong, we're able to provide information from the system to enable the staff responsible to review the situation, understand, and learn what needs to be changed to avoid future events.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
It's been estimated that around the world there are millions of people who are otherwise healthy, have never had a heart attack or stroke, are not at high risk of bowel cancer, yet who take aspirin on a daily basis, convinced that it's going to help them. Well, the evidence from the largest ever study in this area suggests not. A huge trial called ESPRIT, involving healthy Australians and Americans aged over 70, given low-dose aspirin for 5 years, has found no benefits and some harms. The research was led by Professor John McNeill of the School of Public Health and Preventive Medicine at Monash University, who I spoke to before we went to air. Welcome to the Health Report, John.
Thank you, Norman.
It's pretty impressive, 3 papers in the New England Journal. What sparked this study? Because it was Australian motivated, even though it occurred in the United States as well.
I think we've been aware since the 1990s that there's an evidence gap, that many millions of people take aspirin every morning, and the evidence base, particularly for those who haven't had a heart attack or a stroke or have no other medical reason to be taking it, the evidence just isn't there.
So what did you do in this study?
We recruited 19,100 people from the United States and Australia. 16,700 were from Australia, and we followed them for an average of 4.6 years, and half of them took aspirin and half of them took placebo.
And what were you looking for? What were your endpoints?
Well, the endpoint here was disability-free survival, which is a measure of how long elderly people stay healthy.
But how did you measure that?
By measuring how long it took for people to remain healthy without having a permanent physical disability or developing dementia.
And what did you find?
Well, we found 3 things. Firstly, low-dose aspirin did not appear to increase survival.
Disability-free survival or survival?
Disability-free survival and survival. And it also didn't prevent heart attack or stroke. I think I should emphasise that this study was done in people who'd never had a heart attack or a stroke, because people who have routinely take aspirin under very strong evidence to prevent them having another one.
So we're talking about healthy people recruited who were over 70 on average, is that right?
That's right. The average age was 74.
What about cancer? A lot of people take aspirin to prevent cancer, and there is some randomised trial evidence that aspirin can prevent cancer.
Yes, this was a surprising finding in our study. There were numerically more people dying of cancer in the aspirin arm than in the placebo arm. This was a relatively small effect. It wasn't statistically significant once we adjusted for the multiple comparisons that we were making, and it hasn't been seen in other large clinical trials. So we're suspending judgment as to what its significance really means.
And what were the complications and the side effects?
Well, we had the usual side effect of bleeding. We took a lot of care over the measurement of bleeding because older people are more inclined to bleed, and aspirin enhances that effect. And we certainly had an increase in hemorrhage in the people taking aspirin.
Now, previous studies have suggested, and we had this on the Health Report, I think it was last year, suggesting that if there was a hemorrhage risk, it was early on and that settled down later.
We looked at this, but we couldn't find that. And according to our data, the risk of hemorrhage just kept going.
Now, we had a story not so long ago on the Health Report suggesting that the effect of aspirin, of low-dose aspirin, is actually only there in people who weigh 70 kilos or less. And that if you want to get an effect from aspirin, you should be on a higher dose, like 325 milligrams or even 600.
We've had a brief look at that, and we couldn't find that in our older people.
What about dementia?
Aspirin appeared to have no effect at all on dementia.
But 4 years is not a long time to develop dementia. I mean, did you measure cognitive decline?
Yes, we measured cognitive decline very carefully, and we haven't analysed all the data yet, but certainly the number of people who were diagnosed with dementia was the same on each arm. But that raises a very important issue, because we will be following the people who participated in ESPRIT over the long term to see if there is a difference in incidence of dementia or cancer that appears later. And we know that there's been evidence that cancer preventive effect does take 4 or 5 years before it becomes evident. That's one of the reasons why we've been very keen for our ESPRIT participants throughout both countries to continue to be involved and let us follow them up.
Now, if you have hemorrhage or you have side effects like gastric upset or something like that from aspirin, the people who are taking the real thing might have dropped out more than people on the placebo. That could have affected the results?
We did a lot of testing of how many people were taking aspirin. We counted their pill bottles and so on, and we found that basically there was very good compliance with the medication on both arms of the study.
Could this be a phenomenon of, as we are getting older, we're actually not necessarily aging, we're actually living longer, younger, and we're getting less heart disease? Was this population too young, paradoxically, even though they were 75? Were they actually too young to get an effect? Because 75 is like the new 50, as they say.
That's an interesting question. We followed people whose commencement average age was 74 and whose final average age was nearly 79. So that's following people through a reasonably long period. We had a number of people who were over 80 years of age, and as far as we could tell, there wasn't a really big difference between the impact of aspirin at any of these ages.
So if somebody's taking aspirin now, they're entirely healthy, they've never had heart disease, they've not had bowel polyps, which is another reason why some people might take aspirin to prevent the polyps turning into cancer or new polyps emerging, and they're on aspirin, should they just stop?
Look, we're not recommending this at this point. People taking aspirin take it for three reasons. I mean, some, of course, as you said, have had a heart attack or a stroke or something similar in the past, and they should definitely be on aspirin because the evidence is strong. And then there's others who've been put on aspirin by their doctors for a range of other reasons, and they should continue as well, certainly not stop without getting advice from their doctor. But then there's the third category who may have just decided, they've read somewhere, they're perfectly healthy, they think it's a good idea. The results of a spree will lead these people to reconsider whether that's a good idea.
Just finally, do we know the numbers of people who are taking aspirin unnecessarily?
We know that it's much more common in the United States, where about 40%.
The date's wrong.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Five years ago in Victoria, a baby died during a planned home birth. The coroner recommended an investigation into the extent of problems arising from home births. One of the results of this recommendation have just been published. A study comparing thousands of women having their babies in hospital with women having a planned birth at home. Miranda Davies-Tuck was the lead author. Miranda is a perinatal epidemiologist at the Hudson Institute in Melbourne. Welcome to the Health Report, Miranda.
Hello, thank you for having me.
You took data from 15 years. It's an impressive number of women.
16 years, 2000 to 2015.
Sorry, maths was never my strong point. So you were comparing women who went for home births to women who went into hospital. What sort of numbers are we talking about here?
So there are around 4,000 women who planned a home birth and just over 800,000 who planned to give birth in hospital.
And we're saying planned because these aren't women who couldn't get to hospital and had the baby at home. These are women who just wanted to have a private delivery from a midwife.
Yes, so these were women who had made a decision at the onset of their labour to plan to give birth either at home or in hospital.
How did you do the study? What were you looking for and how did you compare the two sets of women?
So we use the routinely collected data that we have for Victoria. So every time a baby is born or a woman is pregnant in Victoria, a whole host of information is collected and reported to the Department of Health so that we can monitor the health of women and babies in Victoria. And so we access that data to compare the outcomes after we classified them as either planning to birth at home or planning to birth in hospital, and whether they'd be deemed to be of high or low risk of having an adverse outcome.
So describe a pregnant woman who's low risk and a woman who's high risk. What sort of factors are we talking about here?
So generally speaking, a low-risk woman is a woman who has a healthy pregnancy. There's nothing majorly wrong with her or her baby. There's only one baby that she's carrying, so she's not having twins. And she hasn't had a previous complicated pregnancy, so one that's ended in a caesarean, for example. In contrast, the women who would be considered or who were considered high risk were predominantly women who had had a prior caesarean delivery. They were also women who were giving birth beyond 42 weeks, so we call that post-term. And then there was a smaller subset of those women that had more than one baby, whose baby was breech, so it wasn't head down, or they had some sort of serious medical condition such as hypertension, etc.
Okay, so like for like, but the difference was the home birth or not. I mean, was it truly like for like? I mean, were women having their babies at home more likely to be better educated, higher income?
Yes, so we saw that regardless of whether they had risk factors or not, they tended to be healthier, older women of a higher socioeconomic standard, if we use what we call CFA. It's a way we categorise them. It's not surprising though, because the women choosing a home birth in this study were doing so privately, so they were paying out of pocket to do that. The type of risk factors were slightly different too. So the high-risk women in hospital were more likely to have medical conditions, which was a little bit higher than the women who planned to give birth at home.
Before we get to the results, did that influence the results, do you think, or were you able to control for all that?
So we made the decision not to control for anything in this study. We weren't interested in the relationship between home birth and outcome, but what we wanted to do was to provide information in a way that women would be able to work out where they sat in that particular group and then make decisions about what their outcome rates would be if they did or didn't have risk factors, and if they chose to give birth in home or hospital.
So what did you find?
So that we found that for the low-risk women, there were no differences in perinatal death. So babies were not more likely to die for women without risk factors planning to give birth at home.
So when you say perinatal, is that the first week of life?
And so perinatal death includes stillbirths that occur during labour and also deaths in the first 28 days of life.
Okay. So no difference in perinatal death. What about other baby outcomes?
So in terms of some of the morbidities or the bad things that can happen to babies, some of these were actually lower for the women who plan to give birth at home. So their babies were less likely to have an injury, and they were less likely to have some of the other morbidities that can occur. But this probably reflects differences in some of the intervention rates that the low-risk women, so they were less likely to have instrumental deliveries and caesarean deliveries, so possibly it could be related to that.
What about the high-risk women?
So for the high-risk women, we didn't see that the perinatal mortality rates was the same. In fact, we saw that...
You got a tripling, didn't you?
No, it was actually 7 times more likely to have their baby die if they planned to give birth at home. Yes, so neonatal death was So death after the baby was born was the death rate that was significantly higher in the women.
For what reason? I mean, there wouldn't have been large numbers, but what reason?
No, so the numbers were very small. We can. It's difficult to talk about the drivers of this because the numbers are so small. But it did look like the babies that were born at home were the ones that died. These were not the babies that transferred to hospital during labour.
So if we've gone into problems with a planned delivery and you transferred to hospital, you were okay. It was just if you got into strife, then that's the women who got into problems with their babies.
Yeah, and potentially there were barriers to the transfer to hospital. Whether or not those barriers still exist right now, we can't be certain.
But all the maternal benefits and the other benefits were there in the high-risk women. It was only that risk of perinatal death that was the issue. Now, there are all sorts of... So in other words, it's basically good news as long as you've got your risk assessed and you're going into this with your eyes open.
Yeah, absolutely. And it's really good that we've been able to show for Victoria what we already know for international studies. So the UK data has been telling us this for a long time, but we didn't have any data to inform us here. So it's good to see that what we're seeing here is the same as what they're seeing in the other big studies internationally.
Now, there are big issues here. Midwives are supposed to have an obstetrician who covers them, and they often find it hard to find an obstetrician who's prepared to cover the midwife and look after them. The midwife feels that they're not easily able to transfer the baby. There's a problem with payment and insurance, getting indemnity insurance. Are we overcoming those barriers yet?
Yes and no. I think certainly a lot of the barriers to transfer are decreasing. We have collaborative arrangements now where hopefully midwives are feeling comfortable backing up and consulting with obstetric staff when women need care. Certainly we see from the data that we have that when a woman has been identified as needing to transfer and transfers to hospital, her outcomes are fine. So in those instances, absolutely.
And just very finally, very briefly, because we're well over time, is this applicable to other jurisdictions in Australia, do you think?
I would say yes.
That is the end of Part C. You now have 2 minutes to check your answers.